Hello, my name is Janet and I'm a publisher with Elsevier. Medicine Journal is a collection of current reviews for internal medicine training exam revision, as well as for continuing professional development. Medicine's editorial board comprises of subject matter experts across all subspecialties of clinical internal medicine. As we publish each chapter in the journal, our chairman, Albert Ferro, will be interviewing the relevant board member and chatting to them about their specialty. We hope you enjoy them. To find out more about Medicine Journal, including how to subscribe, please visit www.medicinejournal.co.uk. You can also follow us on Twitter using the handle @MedicineUK1.
Hello, my name is Albert Ferro. I'm a clinical pharmacologist in London. I'm the chairman of the editorial board of the journal Medicine. So I'm delighted to have with me today Professor Derek Bell, who is a member of our editorial board. So welcome to you, Derek.
Good afternoon.
And maybe you could start by asking you to tell us a bit about yourself.
So thanks very much, Albert. Currently, I'm chair of a group of hospitals in the Northeast, University Hospital Tees, physician by background and clinical academic appointment previously at Imperial College.
And like I said, you're a member of the editorial board. And the reason we're talking to you today is because of the July 2024 issue of Medicine, which is around ethics and communication in healthcare. So we're going to talk a bit about that. I'll start off by saying that obviously it's a very important topic of general interest and importance to everybody who's practicing medicine, but also I'd say it's a very important component of, for example, the MRCP UK exam. In PACES, there are dedicated ethics and communication stations. So a good understanding is not just important for everyday practice, but it's actually relevant to taking exams such as the MRCP UK. We've got a limited time to talk, so we're not by any means going to cover everything that's in the July 2024 issue, but we'll touch on one or two important ones and ask our viewers to sort of read the issue for more detail. Anyway, with that little preamble, Derek, I thought we'd start off by talking a bit about issues around beliefs, culture, religion, all that sort of thing, both on the part of the patient and the healthcare provider, and how this can impact on delivery of healthcare. I wonder, do you have any sort of thoughts and experience in this area?
Well, I think one always does as a practicing clinician. I think what has become more evident over time, and I think it's what is certainly for listeners or readers becomes important, is the increasing complexity of healthcare and the need for us to be much more contextually aware, which includes understanding individuals and personal belief systems and how they might influence a conversation that's taking place, for instance, between a clinician and the patient. If you know, I mean, it is broader than that, isn't it? Because it's often patient and carer these days, particularly in those with disability or more complex needs, elderly patients. So if from a personal point of view, you could always think back and where you didn't quite get that right, and I think that's why it's quite important in the exams like the MRCP actually put you into that situation of having to sort of work through what is a complex grey area question in communication and ethics.
And it does create conflicts and difficulties sometimes, doesn't it? So, for example, the patient with who's a Jehovah's Witness who refuses a blood transfusion when it's thought to be medically necessary. Or on the other side, maybe a doctor who believes in the sanctity of life at all costs, has difficulty with DNA CPR situations or decisions. So those can be quite difficult and challenging to navigate, can't they?
Absolutely. And I think the thing, I suppose, from the profession's point of view is, going back to the ethics, is that we do have to respect the autonomy of the individual, particularly if they have the capacity, if you like, to communicate, or if they've communicated through an advanced directive at that time in the past. We need to be able to respect that. I think if colleagues do have genuine difficulty in those areas, what they must do is look to their peers to see, if they're getting themselves into a complex situation, do they have peers who have managed that situation, or they can learn for, or who will take on the necessary discussion that needs to be had. I think, again, it goes back to, if you're not sure what to do, you ask for help, you communicate with your peers, you communicate with your seniors about how you can best handle a situation. And I suppose the other thing, Albert, just talking about, there is a little bit, isn't there, about making time to be prepared, time to make sure you're in an effective communication mode. That pre-prep meeting that sometimes in medicine people don't spend time on that. Just thinking, like, where could this conversation take me, or how important is this conversation to the individual? Well, it's always important to the patient you're talking to or the carer you're talking to.
I think there's two important things you bring out there: the pre-prep, which I think is very important, and also the importance of not going alone with these things. That you have colleagues, you have NBTs, there are people that you can refer to, even at a senior level. We're not always sure of what the right course of action is, but talking with others can only be a good thing.
Yeah, absolutely. And I think in the area of sort of ethics and decisions that are complex and difficult, there isn't always a single right answer, is there? They are by definition grey, and what you're trying to do is come up with is the best possible outcome, the best possible conversation.
Yeah, no, sure. So that kind of leads me into a related issue, which is obviously very much in the news and very topical, and that's what is often called assisted suicide, or maybe more precisely called intentionally terminating life. Now, I don't think either you or I are going to express our particular views about the rights and wrongs of this, and I don't think it would be right for us to do that. But clearly it is a very hot topic. And one thing that often comes up is the difference between that and stopping treatments that are intended to prolong life. And there is a difference in law around that.
Picking up on your latter point, Albert, I think is that what we all want, one would hope, is that when death comes, that one's death is dignified. And that you have the best possible approach. I think there's also, I think, a little bit of what you talked about is assisted death or euthanasia is at very end of a spectrum, whereas most of the discussions we have are around end of life, and they all have a temporal relationship. An end of life discussion could start at the time a diagnosis is clear that there is an ultimate, if you like, trajectory or end point, or which is probably best for us to try and have the discussion then. But that's very different by what you do then. And as you say, whether you're in those final hours or days where actually stopping treatment is actually beneficial to the patient and can be done with the patient involvement, if you know what I mean. So we're doing it in partnership with the patient or in partnership with the patient and their carer. And it isn't just about stopping treatment. Something like that, is it? It's about, you may be supplementing treatments, but those treatments that you're supplementing are for symptomatic relief. So you're not withholding all treatments, are you? So I think it's an interesting area, and I think the assisted one, I think societal and policy measures will dictate. And the crucial thing is that we as a medical profession, or all clinical professions, are involved in that discussion. I don't mean with the patient, I mean in the policy societal discussion.
I guess it's worth just sort of highlighting that there is, at the present time anyway, it's against the law to intentionally terminate somebody's life, but it's not against the law to stop treatments which are prolonging life where that life is thought to be a difficult one.
Yeah, and I mean, there's another aspect that's actually stopping treatments that may be actually causing, aggravating, if you like, their quality of life, making it worse because the treatment isn't beneficial at that particular point for for the stage of life that they're at. So I absolutely agree, Albert. Absolutely agree.
I guess we'll come in a little while to talk about patients who don't have capacity, but just sticking with patients who do have capacity. And so we've talked a bit about religion, cultural beliefs, but there are other beliefs that patients may have which are not rooted in any religion, culture, whatever. They have capacity, but their beliefs are thought to be counterproductive. Example, the patient with cancer who refuses traditional, treatment in favour of homeopathy or something like that, or herbalism. So that's a not uncommon situation, and again, quite difficult for the doctor and other healthcare professionals to manage that. So you've got a patient there who has fixed beliefs, which you as a professional believe to be wrong and against their interests, but they don't want you to pursue the traditional way of treating them.
So I think, again, this comes down to autonomy, doesn't it? But I mean, I think as our role in that is to, I suppose, make sure that we have explained why we believe, or it is believed, that we think the treatment is appropriate, but recognizing that what we're doing is providing information to the individual to support any decision, even with preconceived ideas that they may choose to. Another thing for me that comes into this, Albert, is that time to reflect. It's the bit about you have given information, they have a particular view. Again, how do we create time for that individual to actually have a further conversation or discuss it with a carer or a partner, or offer opportunities? It comes back to, you alluded to earlier, we have the opportunity, don't we, to involve others, and that others could be a healthcare professional, but it might be a peer, or it might be another patient who's been through similar treatment, if the person was interested in having a discussion with somebody else and you weren't breaking confidentiality. I mean, I know from some recent visits to chemotherapy units that clearly the patients have a kind of will communicate and do communicate, but they find that, some of them find that very beneficial to have a conversation with another patient on an informal basis. Some of them don't want it at all. But, there is the bit about, there are other societies out there and groups that we can refer patients to as well if they want to get second opinions or third opinion. But ultimately, you do need to respect their beliefs. What you can do is present as much information and give them options, but we've got to respect their autonomy.
I think that's absolutely right. You do have to respect their autonomy, which is, of course, different to the case with patients who lack capacity. And there are particular ways that we're supposed to deal with that on there. So if your patient in front of you lacks the capacity to make rational decisions for themselves, and you feel that you have to act in their best interests.
And that's where we do need to follow the legal framework that we've got with adults not just adults, but individuals with incapacity. And the legislation for that actually varies, as you well know, by country. So you need to be familiar with, the local legislation you're operating under, but also we have designated people and systems to support us in that. And that's where we would, with the appropriate, following appropriate frameworks, actually then follow what's in the best interests of the patient. And again, if you've got carers or other people who can be involved in those discussions, it's absolutely crucial to make sure they're engaged and they understand why you're making decisions. And I suppose the other bit around that, not just in relation to incapacity, Albert, is actually we need to make sure that we've clearly documented the decisions that we've made, and the purpose behind them, and also be prepared to review them if that doesn't actually work out to be the right step.
Important in all of this is the Mental Capacity Act, which basically outlines the principles under which you should establish somebody's capacity. There is a good chapter on this in the issue. It's called Ethico-Legal Considerations in the Assessment of Capacity. And I might just sort of read out the five principles of the MCA here. First of all, capacity is presumed unless it's established otherwise. Secondly, all practical steps must be taken to optimize capacity. Third, an unwise decision is not sufficient grounds for deeming someone lacks capacity. Fourth, if someone lacks capacity, a decision must be made in their best interests. And fifth, care must be taken to avoid unnecessary restriction of right or freedom of action. So those are, I think, really important guidelines around capacity.
Oh, absolutely, and I think the one that they're not hierarchical, as you know, in real terms. But I think we should always be operating in best interest, should we? And we should always be operating in best interest. The optimizing bit is quite difficult, isn't it? Depending on what, again, the temporal relationship of decisions is quite important, isn't it? If there's something that's very acute and you don't have a lot of time, as opposed to something where you may be able to optimize it because the decision doesn't need made there and then, and you've just got to operate within the best, and that's where you need, I think, and you do have in most organizations people who can help you, guide you through that, and make sure you've got the appropriate support and completed the appropriate documentation.
And I think what I'll also allude to is there's a related act, the Mental Health Act, which is relevant to people with actually mental health disorders. So it's all in that chapter. So we'll refer our viewers to that. And just briefly before we leave that, just your views about whose job it is to assess capacity. Is it the job of a general physician like you or me, or is it the job of a psychiatrist, or should it be done in conjunction?
I think it depends on the situation you're dealing with, doesn't it? If it's something that's life-threatening and it's 2 o'clock in the morning, you probably have to act as a general physician within the appropriate boundaries of that. If, again, there is more time or there are other options, then actually working as part of a team to do that. I think if you're in doubt and you have time, then you embrace your other professions and other colleagues with the expert knowledge to do that. But if you're in doubt, you should always take additional advice from people who are skilled in this area.
Thank you. Thanks, Derek. And maybe we'll just sort of finish off with a bit of a discussion around risk communication, which I think is another very important aspect of how we communicate with our patients. Now, the way we think about risk is probably very different to the way that most other people think about it. We tend to think in scientific, in probabilistic terms. Other people, it kind of depends a bit on their numeracy skills, their preconceptions, their backgrounds, and so on. So the way that we communicate risk and benefit is a difficult one. I'd just be interested in your thoughts around this. This is obviously a kind of situation you found yourself in quite often, really. And how do we get it right when we're talking to our patients about benefits, risks, and so on?
For certain conditions, as you know, there's already good, if you like, literature-based pictorial representations of how you represent risk of an individual in relation to a population, which again does require your ability to communicate, people's ability to handle the information. Because what does 1 in 10 mean to the individual if you're not the 10th person? But I think we've got to look at different ways of how we do that, and where we have tools and techniques that we can actually explain our risk in ways that are meaningful to the individual, then we should take them. But we should use the evidence-based tools that we've got. So, for instance, for cardiovascular risk, what's our risk of requiring treatment for hypertension, or what's our risk for cardiovascular protection if we've got other risk factors? So we need to use our risk scores, and we need to then translate that to, well, what does that mean to an individual? But of course, that doesn't always apply in some life-threatening conditions where you've got to consider things in a more immediate fashion. But in general terms, for most of the discussions I think you and I are talking about today, we have time to go back over this. And this, again, I think is where nurse specialists and other members of the multi-professional team come in. It's that bit about reinforcing the conversation, and also going back to the pure communication aspect of this. It's that checking the understanding, isn't it? I have said, what did you hear? What have I missed? It's going back through that communication loop that we should always be practicing. And one of the things I was going to say in this conversation, I think if you just overall, is that the communication aspects, it's where we get most complaints in the health service. We need to spend more time. We need to create the time to be able to communicate effectively.
Yeah, I totally agree. I think, it's usually where communication is broken down that we get the complaints, the bad feeling, and so on. As you also rightly point out, it's the question of creating the time for that. And that's a very difficult one for most practitioners, isn't it? Because we're very time poor. But actually, proper communication does require time to do it effectively, and also to reinforce it to the patients as well.
Yeah, I mean, I suspect we don't, and handing somebody from one professional to another doesn't always create the kind of communication scenario you're trying to create, because it can often create, well, you're quite busy, therefore I'm going to get somebody else to talk about. So we need to think about how we manage that kind of interplay between the different elements of the team. I think there's a lot about going back, though, if where you've got the time to do it, to reiterate, you're not trying to force somebody, or force is the wrong word, but, create a decision point that you don't actually need in that particular point in time.
Derek, I think we've probably run out of time here, but I think that's been a very useful discussion. Just to say for the viewers that what we were talking about with communication of risk, there is a very good table 1 in the chapter on ethical aspects of risk communication. And I think that's a very good guide for people to use. It's on page 430 of the issue, so I'll refer people to that. Once again, Derek, I just want to thank you very much indeed for your time speaking to me today. Thank you.
Well, thanks very much for guiding me through that, Albert, as well. Thank you.